For years, women with a history of breast cancer have been told no hormones ever again. But new research and a new generation of clinicians are questioning that absolute. Today, we're unpacking the fear that continues to surround hormone therapy and cancer and what the evidence really says now. Welcome to All About You. I'm Dr. Shauna Watts, GP and women's health advocate. Every week, I share evidence-based conversations that help you navigate the changes of midlife with clarity and confidence. Today, we're tackling one of the most misunderstood topics in women's health, hormone therapy after breast cancer. By the end of this episode, you'll understand how one decades-old study spread fear about hormones and what modern science now shows that could actually change your life. What it really means when breast cancer is described as estrogen receptor positive, and why progesterone is an important yet overlooked hormone for this stage of life. Remember, this is general information only, not personal medical advice. Always consult your own healthcare provider for guidance. My guest today is Dr. Corinne Menn, a board-certified OB/GYN, certified menopause practitioner and breast cancer survivor. After experiencing treatment-induced menopause herself, Dr. Corinne became passionate about bridging the gap between cancer care and menopause care. Through her clinical work and her educational content online, she's helping women and their doctors understand that the HRT conversation isn't black and white. Corinne's known for translating complex research into clear, compassionate advice, and she's changing how we talk about survivorship and midlife women's health. Welcome back to the podcast, Dr. Corinne Menn. I'm so delighted to have you back. I loved our first conversation, and I'm excited to talk to you again.
So happy to be back. Love talking to you.
I want to jump in for any of our listeners who didn't hear our first podcast and ask you if you wouldn't mind telling us a little bit about your story and how you've ended up where you are.
Absolutely. So I was a second-year OB/GYN resident in 2001 when I felt a lump and I was diagnosed with early stage breast cancer. Interestingly enough, it was really the same year. It was the end of 2001 going to 2002. And so everybody talks about where they were when the Women's Health Initiative results were announced, right? But I don't remember the WHI being announced because I was in the middle of chemotherapy, premature menopause, having terrible symptoms, and we can talk all about that. Totally unprepared by my doctors, totally unprepared personally and professionally to help myself, much less anybody else dealing with menopause or premature menopause. And in July of 2002, I was in my program director's office saying I needed to take a short leave of absence because, the collateral damages of treatment and chemotherapy were so profound. And so fast forward, after a long journey, premature menopause twice temporarily due to cancer treatments, and the third time permanently when my ovaries were removed in my very early 30s. From that process, I realized that I didn't have the skills to help myself or my patients. And so then it was a kind of a long journey of continuing medical education that I had to get on my own, and then really starting to tailor my practice to helping women who I think are the most dismissed in healthcare, right? Certainly young breast cancer survivors. I dismissed my own lump and wrote it off for a few months, told I was too young for breast cancer. So it was the first time kind of understanding as a patient that, women get dismissed for their concerns. And then learning how my other concerns like that menopause, sexual health, et cetera, chronic disease risks were dismissed. Kind of just leading to today where now this is what I specialize in and this is what I do, with a focus on really the most complex menopause cases and certainly breast cancer survivors.
Yeah, okay. Such a profound story, but giving you such incredible insight into how these women are feeling. Corinne, I'd love to step back and understand, when did breast cancer become so linked to HRT? And then when did people who've had breast cancer become so utterly banned from having hormones? Was that always the case?
Kind of thinking when I was diagnosed, right? So that was, the early 2000s. So this was the era when, and even, the years leading up to that, where, adjuvant endocrine therapy, first of all, became a very important mainstay, treatment for ER-positive breast cancer. And 80% of breast cancers are estrogen receptor positive. And just to note, estrogen receptor positive breast cancer doesn't mean that estrogen caused your breast cancer, because all of our breast cells, healthy ones too, have estrogen receptors. All of the cells in our body have estrogen receptors. But I explain to patients, if those cancer cells, if those cells turn cancerous and they retain or they overexpress that estrogen receptor, well, blocking that estrogen receptor is one way that we can help control the cancer, right? But, getting back to, for ER-positive breast cancer, blocking and lowering estrogen levels is part of the initial treatment, right? And so, of course, kind of from a very simple standpoint, like, people then become very afraid of the hormone estrogen. And around the same time, the early 2000s, the Women's Health Initiative was announced. The results were announced, and a lot of myths and misinformation came out of that misinterpretation and really the mismessaging. It wasn't that it was a bad study, it just was communicated poorly. And so that led to lots of general fear in the average population, women who did not have cancer. They became extremely afraid of HRT because of this supposed, link between breast cancer and HRT. And we can talk about those details and why really that information was not relayed correctly, right? So I think it's kind of a double duty why breast cancer survivors have been completely not only shut out of the conversation on could they ever consider hormones in some form after breast cancer, either local or systemic, right? But it also just made it almost like taboo or just not important to talk about menopause in these women. Because what I also always want to remind people is that even if you can't take systemic estrogen, we just can't ignore, like I say, the pink elephant in the room, that like the menopause is happening. It's often happening earlier, more abrupt, more severe, prolonged estrogen deficiency, profound deficiency. It's not just natural menopause levels, it's very low levels. So I think, it's not just that they don't have access to hormones. It's that they don't even have access to really, I think, proper survivorship care when it comes to these things, right?
There's so many things I want to jump into there. Thank you for explaining the thing about estrogen receptor positive. Honestly, I genuinely believe so many doctors do not understand this. Um, Patients don't understand it, but I've had so many patients who've been told that their HRT caused their breast cancer or HRT caused their mum's breast cancer. It's not even like a thinking from 20 years ago. I was literally had a patient in recently whose sister had taken hormones for 7 months, has been diagnosed with breast cancer, and is now full of regret thinking that she caused this by taking these hormones. And apparently her doctor said, yes, probably that's the case. And I'm like screaming inside going, no, like that
No.
is not the case.
It's not even biologically plausible, like, and it's a shame because the medical oncologist, frankly, has a responsibility here. When a patient's diagnosed with breast cancer, they always want to know what caused it, right? And really, we don't know what causes breast cancer. We know what might increase risks for breast cancer, but medical oncologists know, they know damn well that cancer does not start from one cell and go to a clinically palpable or detectable mass or lesion on, a mammogram or, an MRI in 7 months, right? So even if this one was on HRT in some form, that breast cancer takes often years for it to go from the time it started growing to it being clinically relevant, right? And so right there it is just a basic principle. Now, if you have estrogen receptor positive breast cancer, right, and it's undetected or you don't know you have it, and you're taking some HRT, is it theoretically possible that it might, move things, maybe it'll grow a little bit faster while you're on the hormone therapy? Yes, but that doesn't mean it caused it. And in fact, in the studies that showed, even in the Women's Health Initiative, women who are diagnosed with breast cancer while taking hormone therapy, the breast cancers tended to be of better prognosis, a lower stage. And generally, women who were on HRT are getting regular medical care. They're getting mammograms. They're being seen more frequently. So it's much more likely that we actually catch things sooner rather than later. It's just a little bit lazy medicine. It's really easy for a doctor to be like, well, it was probably that, right? That's what caused it. They forget to tell the patients that there are hereditary genetic factors, there's environmental factors, and also just chance, right? Because dividing cells sometimes go awry. And breast cancer is a common the most common cancer in women. So, women who are taking HRT and women who are not taking HRT as they get older, there's a chance they're going to get cancer, whether they take HRT or not, right? And so I think that's important for women to understand too, because a lot of women blame themselves when they're diagnosed, right? They even blame themselves thinking like, well, what else did I do? Did I drink too much? Did I have too much sugar? Did I not move my body enough? What did I do wrong? Right. But it's funny, we don't really think about that with many other cancers, right? You don't see men with prostate cancer running around thinking like, what did I do to cause this? Nobody says that. They just think, how are they going to prevent these men from losing their erections? That's what they're worried about.
Yeah,
I
100%.
mean, talk about a double standard there.
Yeah, 100%. One of the other things that you touched on was family history, and this seems to be something that causes so much confusion. So many women will present and say, "Oh, my dad's auntie had breast cancer, so I can't have hormones," or, some distant relative. But, whenever you think that 1 in 7 women in Australia and New Zealand will have breast cancer in a lifetime, well, if there's 7 relatives in your family, then you're likely to have someone somewhere who's had breast cancer, and that doesn't mean. So can you maybe just address that and explain who are the people that need to be concerned and who are not?
Yeah, I mean, I think it's important for people to know that most women who are diagnosed with breast cancer do not have a significant family history. So, on one hand, I don't want any woman to say, oh, well, I don't have a family history, so I don't need mammograms or I don't need to be, thinking about screening. That's not true, right? 80% of breast cancers are not hereditary, right? Probably about 5 to 10% are due to an actual genetic mutation. And we mostly think of the BRCA gene, and there's some other genes. And then there's another, small group, another 5 to 10% or so that are there is some hereditary factor, but not something that we've identified, like a specific mutation. It might be like a more slight predisposition. So I always say to women, I want to know your family history. I also want to know other risk factors, and we can talk about what the other risk factors for breast cancer are. It's not just your family history, right? So that I know how I can screen you, that I know if you need enhanced surveillance, to know if you need genetic testing or other preventative things that we can do. But I don't want to know those things so that I can deny you access to treat your menopause symptoms or to deny you access to use hormone therapy to lower your risk of osteoporosis. And in fact, I want to know your risk because I might also want to offer you a certain HRT over something else because there are different formulations and there might be some that are better suited to women who are maybe at a higher risk, and also to offer you the full range of options. But this knee-jerk reaction that mom or my aunt had breast cancer, so I absolutely, my doctor says, nope, not for you. It's not based on any facts. And frankly, the Menopause Society position statement, I'm not sure what the Australian position statement says. It says that the preponderance of evidence suggests that hormone therapy does not further increase above the baseline risk based on density, family history, other factors, right? So, like I tell women, if the average woman's baseline is here, and if yours is a bit more elevated because of a family history or other factors, well, then that's your baseline elevated risk. Now, if we go ahead and add hormone therapy to that risk, to that your baseline risk, it doesn't appear to further elevate things, particularly not the hormone therapy formulations that we use today, right? So I think that's like a basic concept that I try to explain to women.
Yeah, no, that's such a great explanation. And so basically what you're saying is that everyone has their baseline risk, whatever that happens to be for them as an individual, and us adding hormones in does not appear to change whatever your personal risk is.
Yes, and that's what the data suggests. Now, listen, we know that it all comes down to individualization, right? There's different hormone therapies out there, and the big Women's Health Initiative, which still was a very important study, we learned a lot from that. We don't want to kind of throw all that data away. We've learned a ton of safety data. I always say the WHO showed us how safe hormone therapy actually really is. And what we saw is that the estrogen alone arm of the study in women who didn't have a uterus, they had a lower risk of breast cancer. So that's conjugated equine estrogen. And there are other data points showing that estradiol alone likely is similar. Probably conjugated equine estrogen might have an even lower risk of breast cancer. If your baseline is here and you get conjugated equine estrogen and perhaps estradiol, according to some other studies that aren't quite as robust as the WHO, your risk was actually lower taking the estrogen. Now, when we bring into those synthetic progestins, we have a responsibility to explain to patients that in the Women's Health Initiative, they showed a statistically not significant, but there was an increased risk, but it was tiny. It was less than one additional case for every 1,000 women diagnosed. But even that data comes under fire, and that's a whole nother discussion. But if we take worst case scenario and using that data, if we believe it, at face value, it's a tiny increased risk. And we suspect most of the risk is driven by this increase in breast density that comes from the synthetic progestin. So then we go a step further and we can remind patients that we have data, not perfect data, but we've got a lot of data suggesting that the non-synthetic formulations like progesterone do not have that same negative impact on breast density and do not appear to be associated with an increased breast cancer risk. So that's why it's a lot more nuanced than just telling patients HRT caused your breast cancer. I mean, it's way too simplistic and frankly very harmful message, right? I'm sure you see this all the time that women are whittled down to only their breast risk, right? We're more than our breasts, right? So even if we have a slight increased risk, we must balance it against the benefits. And the benefits are many, which we can certainly talk about.
This episode is brought to you by my 16-week Rediscover You program, designed specifically for women navigating the challenges of perimenopause and menopause. If you're dealing with disrupted sleep, mood changes, or unexplained weight gain, this evidence-based program combines medical guidance, practical tools, and a supportive community to help you take control of your health. Women have reported significant improvements in symptom management of sleep quality and overall well-being. As an All About You listener, when you mention the podcast, you'll gain priority access for our next intake. Click the link in the show notes to learn more and join. I'd love to help you rediscover the vibrant, confident version of yourself. So, Corinne, can I just ask you just to speak to what are the risk factors for breast cancer?
I like to think about the risk factors for breast cancer as things that are modifiable and non-modifiable, right? So the non-modifiable things, we can't change, your genes, right? So if you have a strong family history, if you have such a significant history that you find out you carry a genetic mutation like a BRCA gene, well then that's something we can't change. But we can do things to lower that risk. Other things we can't modify is like the time you have your period, right? So an early menarche. We don't always have control of how many children we have because we know having a pregnancy and breastfeeding helps lower the risk. So I don't think we can always control those things, right? That's just how life takes it. But there are things we can control, like being a healthy weight, eating a really nutritious, I say a nutrient dense, like anti-inflammatory diet. You don't have to be crazy and follow some really specific diet, but just eating lots of fruits and vegetables, having lots of fiber, and like not having processed foods and alcohol. And I think that when we talk about this increasing rates of breast cancer in the world, we really have to focus on these modifiable risks. It doesn't mean that someone who gets breast cancer should be blamed that they didn't live a perfect life, because we've both met many women who were marathon runners and super clean eaters and all, the rest, doing all the screening, and they still get breast cancer, right? But these are some things that might help lower your risk, right? And when people think about, well, why are rates rising in younger and younger women, and not just breast cancer, cancers across the board, I think we all have to just look and see, like, we live in a more toxic environment, toxic stress, toxic food supply, lots of inflammation, lots of obesity, and lots of alcohol. A lot of binge drinking earlier and earlier, more and more. A real wine culture amongst the moms and binge drinking culture in the young people. So, I think those are modifiable things that people should frankly be a little bit more scared of than HRT. Right? So, it's frustrating to me when someone's like, "Well, I'm not gonna take that HRT. I'm going to suffer with my hot flashes. I'm gonna put myself at risk for osteoporosis. I'm not gonna, learn about the benefits, but I'm gonna go hang out with my friends on a weekend and, like, down lots of drinks." I'm like, "So then really, do you understand risk?" I would say not.
100%. It's definitely a very cultural thing in Australia for middle-aged women to, the weather tends to be good and people tend to have wine at night and things. And it's kind of like, I think sometimes we're scared of the wrong things.
Yeah, and I don't want to vilify anything in life, but, like, you just have choices and you should understand risks, and so when we look at relative risks, the relative risk of worst case scenario, when I kind of refer to the synthetic progestin, and if you wanna believe all of the data out of the WHI showing this, like, very slight increased risk, right? Um, Actually, the risk is slightly higher in women who drink or live a sedentary life, have dense breasts, etc. Right? So it's not this very high risk, right? That people have it in their back of their mind.
Corinne, can you explain what you mean by synthetic versus what some people call body identical or bioidentical hormones?
Yeah, I think important that when I'm talking about hormone therapy that we recommend, I do recommend FDA approved, well studied, government licensed, formulations. And so sometimes bioidenticals, people refer to that speaking that those are compounded hormones. Bioidentical hormones can be compounded, bioidentical hormones can be licensed and FDA approved. And then there's synthetic hormones that are also FDA approved or licensed. So body identical, bioidentical simply means that the chemical structure is the same as the chemical structure that your ovaries make. So estradiol looks like estradiol, right? Now, all these hormones are technically synthetically manufactured in a lab, right? We're not picking, estradiol tablets off of the estradiol tree, right? So like they're all made in the lab, let's be real, right? But what we've learned is that the bioidentical formulations of estradiol and progesterone seem to have a better overall safety profile. They have great benefits, they're well tolerated, but I never want to throw away or people to be too afraid of that synthetic is bad, right? So conjugated equine estrogen, I mean, I guess you can call it a bioidentical because it comes from an animal, right? It's as bioidentical, I guess, as it gets. It comes from pregnant horse urine. Um, but then, of course, it's also synthesized and put into a pill form, right? That is actually a great form of estrogen for some people, right? Because that alone and the WHI showed a lower risk of breast cancer when women were taking it. So I wouldn't be afraid to use that, and I'm not. And there are synthetic progestins that we tend to use as second line because they seem to have a slightly more inflammatory nature and a little bit more increase in breast density. They might have some other side effects that we don't like as much, but they're still overall incredibly safe and they can do a really good job at protecting the lining of the uterus for women who have breakthrough bleeding and spotting. Some women just do better on those, and I am not afraid to use them. But our first line tends to be the licensed FDA approved bioidenticals. And so if you're listening, you do not need to go and get a special compounded concoction to get bioidentical hormones. I know in Australia and in the US, we've got patches, we've got sprays, we've got gels, we've got tablets, we've got vaginal hormone options. All are bioidentical, right? And if you need a synthetic, then you need a synthetic, and that's okay.
I have some patients who come to see me and they've been taking troches for years. And I have to say, I'm originally from Northern Ireland. And then when I came here, I had no idea what they were even talking about. I was like, what?
Yeah, those trope shows, yeah.
What are they?
So those are from compounding pharmacy. They're like a little kind of they're like kind of like a sublingual, a little kind of like a you put it in your mouth and it kind of melts and kind of, you don't have to swallow it. And it kind of gets absorbed, that way. And so I don't ever prescribe them. I mean, listen, some women, I've seen them. They've come on these troches, they call them. We just don't have the same pharmacodynamic studies. We don't really know how much you're absorbing. And I just remind patients, like, if part of the reason you're taking hormone therapy is to protect yourself from osteoporosis, or you want to get some of the cardioprotective benefits or dementia benefits that we know can happen when we start the hormone therapy early. It doesn't mean that it's approved or recommended as first line for prevention of dementia or for heart disease. But for God's sakes, it's okay for us to say that we've got data that suggests it may be helpful when we started earlier. But we don't have the studies that show it in troches or in creams that are specially compounded for systemic hormones. So, like, while they may treat symptoms, we just don't have the robust data that you're getting all of the benefits. So I just remind patients, even if you're doing well on those, do you really know that it's getting absorbed enough to truly help your bones, for instance, right? So when I tell that to patients, they're like, "Oh, that makes sense." And often people pay more for those formulations than they do from the other ones. So, just something to kind of keep in mind. In the end, it's patient choice, but I don't prescribe them.
Yeah, no, me either. Another question that we got asked was, why do we give estrogen transdermally, but then we give progesterone via a capsule? And I definitely have patients who will describe having had progesterone creams. I'm not entirely sure where they're getting that from, but can you explain that one?
Yeah, very, very common question because it gets confusing because they hear transdermal's better. They think, it's safer. Well, when we're talking about that, we're really talking about estrogens, right? So when estrogen is given orally, it gets broken down and has to be metabolized by the liver. When it gets metabolized by the liver, then there are clotting factors that get produced, and it can slightly raise the risk of blood clots. That risk is incredibly low, not statistically significant. It has been shown in women who are early in menopause or who don't have elevated baseline risk for clots. So oral estrogens are incredibly safe, right? We give them all the time in much higher, more potent synthetic forms in birth control pills, right? So birth control pills have a much higher risk actually of clots than oral HRT or oral estrogen and HRT. We tend to like to give it transdermally um, when we are concerned about clotting risk. So in a patch, a spray, or gel. Now, when we're talking about progesterone, unfortunately, what we have learned is that progesterone is a very large molecule. It does not easily absorb via the skin. So when women are getting progesterone creams, sometimes they tell me that they feel better, or, they feel like they've had some symptom relief with it. And I don't know, maybe that's true. Maybe some is getting absorbed, but what we know is it's not nearly enough to adequately protect your uterine lining, right? That's the number one reason, not the only reason, but the number one reason why we have to give a progestin or a progesterone. So if you're out there listening and you're taking a progesterone cream and you're taking systemic estrogen, just remember you're probably not getting enough protection on your uterus, on the lining, right? Now, there is in the US, I don't know if you guys have it, there's a combination patch in the US that has an estradiol with a synthetic progestin in a transdermal patch form, but there is no patch form of progesterone. The other thing is progesterone taken orally doesn't increase clotting factors. It doesn't raise your blood clot risk. So it's kind of like comparing apples to oranges. And then the other thing is the nice little side effect of helping with sleep and feeling, a little drowsy with oral progesterone, you simply don't get it when we're applying it, in a cream form. So I've never written a prescription for a progesterone cream. And if you're getting a prescription for that, I'd really go back to your doctor and say, why are you giving it to me like this? Because this is not what is recommended. Yeah.
Yeah, 100%. What's your approach to women who either have a hysterectomy or maybe they've got a Mirena and so they don't have to have progesterone, but they're feeling anxious or they just are not sleeping? Are you here for giving them some progesterone if we can have the benefits of that?
100%. Particularly I find this comes up in my younger patients who've had their uterus removed for, say, fibroids, when they left their ovaries there, and they're not menopausal yet. They're, say, in perimenopause. Those women still have some fluctuating hormones, right? Their estrogen is going up and down very erratically. They're not ovulating as frequently. They're having very low amounts of progesterone. Some of these women really benefit from progesterone, sometimes even alone, just like we would do for a woman who still had a uterus, right? And it's not wrong to consider giving them, some progesterone. And women who have the same thing with the IUD is going to do a good job of protecting that lining. It's going to be a good job if you still need it for contraception, because women in perimenopause who stored estrogen can still ovulate, right? So the IUD works great, but I often see that low grade anxiety and that anxious feeling, particularly at night and sleep, can be incredibly improved by just some oral progesterone. So it's not contraindicated. I say it's just we don't have to give it, but it doesn't mean that there's no reason to give progesterone. I always think that progesterone is like an unsung hero in hormone therapy, and while we have all this great data that estrogen alone, if you don't have a uterus, seems like the safest, quote unquote, on breast, progesterone added to it seems incredibly safe as well. And there are progesterone receptors on your brain, on your bones, in other places. And, unfortunately, we just don't have enough data that has really explored all those benefits. I wish we did. We probably won't get a lot of data in that because progesterone is very cheap and there's no drug company out there that's going to do big studies looking at the health benefits of progesterone supplementation.
I agree. She's the underrated sister. But I was chatting with a patient about this yesterday, and he said to me, "Oh well, hopefully, there's lots more research happening, and we're going to get all this data." And I was like,
No,
"Is there?
it's not going to
I'm not
happen.
sure that there is."
No, and I think it's okay to tell patients that. And there are people out there who says, "Well, we just don't know, so we can't offer it." I said, "No, we can look at all of the data that we have, and we can say we have really robust data for this, and there are other areas we don't, and we're not going to unless I mean, you're going to wait until this woman's going to be dead by the time presenting data on some of these things, right?" And so I think we make medical decisions based on the data that is available and also on our clinical expertise. People get confused on the definition of evidence-based medicine. They think evidence-based medicine only means randomized controlled studies and only means, what was the latest published paper. But evidence-based medicine is three things. It's the best clinical evidence. And so if we have that evidence, RCTs, awesome. But it's also clinical expertise. It's why we go to medical school and spend years and years caring for patients and accumulating this wisdom, and kind of having all these touch points and kind of knowing how to have all the nuanced care. And then the third part of evidence-based medicine is the patient experience. What is the patient's values? What are her goals? What are her individual risks and benefits? And when you put those three things together, that's actually the definition of evidence-based medicine. So when someone says, "Well, there isn't enough, it's not in the guideline or there's not enough evidence on that," I'm like, "Well, that doesn't mean it's not evidence-based medicine for us to discuss the whole picture, right?" And so I think that gets really lost in the shuffle when people are talking about, counseling women, particularly in the areas of medicine where we do have limited data. And that's why we have to lean on, those three components, right?
I want to talk now, if you don't mind, about two groups of women that I'm starting to see more of. And the first one, an example, was a patient who actually saw me yesterday. She was 39. For non-cancer reasons, she had had her ovaries and fallopian tubes removed, and she left hospital with no hormones. And she describes, in her words, were that I had a complete breakdown, I couldn't cope, etc., etc. I think at about 10 weeks, she saw a doctor and begged for hormones, and someone put her on one pump of estrogel and told her to try that for 3 months. Um, and I was kind of aghast at this because this girl is 39 years old and we're giving her like a minute dose of hormones. And I know that you're passionate about this topic. Can you explain why women who have an early menopause or very early menopause actually shouldn't be given this really low dose, and that we're actually having a completely different therapeutic goal here?
Yeah, it's really important. And we should just remind anybody listening to this, this is not controversial. We have had guidelines on how to treat premature ovarian insufficiency, premature menopause, and early menopause for a really long time. And there's actually very good consensus internationally on this, right? Nobody's fighting about this. Okay. If you lose ovarian hormones prior to the age of natural menopause, which is average age 51, range 45 to about 56, right? So anything prior to 45, but especially prior to 40. We've got very robust data that shows that is estrogen deprivation prematurely that has serious consequences on your current health as well as your long-term health. That it's not really up for debate. Very high risks of cardiovascular disease, osteoporosis, dementia, Parkinson's, sexual dysfunction, mental health, anxiety, depression. Um, you name it. And so the vast majority, all of that can be prevented, right, by just simply replacing and mimicking the hormonal environment that would have been there if you kept her ovaries intact. The recommendations are, unless there's some true medical contraindication, and in your patient that you kind of profiled, she had no contraindication. She must have full HRT. And I say HRT and not MHT. And I know we throw those terms around interchangeably, but kind of this modern preferred term of MHT, menopausal hormone therapy. That's fine. That's for women who are naturally menopausal, and we're using lower levels to ease symptoms, and they're enough to prevent osteoporosis in that population. HRT, so full hormone replacement therapy. I use that term really when I'm trying to educate on this for these women with premature or early menopause, because we need to mimic and get them up to about what they would have had, right? So that means using the highest dose patch, the highest dose pill, the highest dose gel, right? To give them and giving them the progesterone back, and also consider testosterone, because these women have lost one of the major sources of testosterone. We know testosterone doesn't go off a cliff in menopause. We know it's a slow decline, and that decline, thanks to Sue Davis's work, shows us that decline starts happening right in the very late 30s, basically going into your 40s, right? And so a 30-year-old, a 39-year-old, a 35-year-old, a 28-year-old, I mean, this happens, right? Those women don't have very low levels of testosterone. They have higher. And so we have to also think about that, right? But it's a huge problem. In the UK, there was just a study that showed women who were discharged from the hospital with some sort of surgical menopause prematurely. I think it was like less than 5% of them were actually given a prescription for HRT. The numbers vary. There's other studies that show it to be a little bit higher than that, but it's still grossly underutilized. I liken it to medical malpractice, frankly, because we have the guidelines, it's the standard of care, it's FDA approved for premature menopause, and it's completely underutilized. And this is female castration, right? That is what it is. It's a shocking thing to say, like castrating women, but that's what it is. You're taking out the organs that produce their hormones, and you're not replacing them. And if this was a young man, a 32-year-old man, imagine taking off his testicles and saying, let's just see how it goes. And we'll give you like the smallest amount of testosterone, and we'll wait though. We'll wait until you're really suffering and begging for it. And then maybe then we'll give it to you. I mean, it's simply not done, right?
Thank you for explaining that so well. So again, and then another group of women that I see, and I think, a bit like you, they're attracted probably to me because of my BRCA1 stuff, is women who are sort of post breast cancer. And I appreciate this is a very nuanced individual conversation based on that person's, symptoms and how they're going. But I do see a big group of women who are struggling horribly with genitourinary syndrome of menopause symptoms. Like, it's massively impacting their relationships, even their ability to go to work. And then I also see a lot of women struggling with the mental health symptoms, who we end up jointly making a decision, usually mostly with their oncologist on board, that actually their mental health symptoms are so severe that we really do need to consider putting them on hormone therapy. But like, I find that so many women tell me they can't even get people to have the conversation with them. Um, what do we do about this situation?
I totally agree with you. It's a humongous problem. And, we have to recognize that, there's millions and millions of breast cancer survivors out there globally. And the numbers are growing and they're being diagnosed younger, but they're also surviving. We've got better treatments. And so we can no longer ignore this massive amount of women who are survivors of breast cancer. What are we going to do with them when they're surviving their disease, the disease that they're being diagnosed with at a younger age? And so they're living with the collateral damages of estrogen deprivation, early menopause, or just simply beating the cancer and then eventually going through natural menopause, right? We can't ignore them.
They're suffering, so some of them are, like, clearly really suffering. I've had many of them telling me this is worse than my treatment for cancer.
100%. We hear it all the time, and it's not just our opinions. There are many studies that have documented this very, very well, throughout the world, from the US, from the UK, from Australia, right? So we know that the suffering is huge and that the needs are unmet. And I think a couple of basic principles, right? One is breast cancer is heterogeneous. It is a different beast for every woman, right? It's as unique as your thumbprint, right? Your breast cancer is different than this woman's breast cancer, right? It depends on the stage, the type of breast cancer, the grade of it. Is it hormone receptor positive? Is it hormone receptor negative? What treatments did you have? How did you respond to those treatments? There's so many factors, different genomic profiles of the tumor, different rates and risks of reoccurrence, right? So we can't treat them with a one size fits all approach to menopause. That's number one. So the most important thing is, first, what is your, understand your breast cancer. What is your breast cancer risk? You need to be treated. Okay. So you have to get through your treatments, but we should be able to help manage the treatments so that you can get through them, because sometimes, by just helping a woman with her menopausal symptoms during treatments, it allows her to actually complete the treatment, right? That's really important. And a lot of the menopausal symptoms get in the way of completing the treatment. I like to kind of separate out the menopausal symptoms and kind of separate out things that we can treat with local non-systemic hormones. So what can we do to treat the genitourinary syndrome of menopause with local hormones? That's a much easier conversation. And then let's then look at all of the other symptoms and try to kind of separate those symptoms out, right? I've been using this analogy as like these breast cancer survivors, me included, we carried a lot of bricks on our back. Like, there's all these weights, on us. And if we could just take off a few of those bricks and alleviate a little bit of the suffering, she's able to stand a little taller. She's able to breathe a little bit easier and just be like, I can get through this, right? But we're not helping her with any of it, is what's really happening. So when we talk about genitourinary symptoms, that's like one brick that we can alleviate a lot of the pain and suffering, right? So local safe vaginal hormones can be used for all women who have had a history of breast cancer or currently are being treated for active breast cancer, right? And we can go into those details, right? Um, so I think local hormones and then the systemic hormone question. So that's like the first way I start to break it down. Is that how you kind of see it with your patients?
Yeah, 100%. I think one of the things I just would like to, get you to help me emphasize is that vaginal hormones, some women still seem to get really nervous. And I know we're going to talk a little bit later about the leaflet inside the vaginal hormones, which doesn't help the situation. But they still get really nervous because they're thinking, but I'm on a hormone blocker. And is it not really bad that you are giving me this vaginal hormone? And also, won't my hormone blocker stop this vaginal hormone working anyway?
No. So I understand why they're confused. It is confusing, right? But this is why it's really important for doctors to explain how the patient's medications work. So, first of all, women who are in active treatment and they're on a hormone blocker, well, what do they mean by that? Tamoxifen is one of the most common medications. And so it blocks estrogen receptors in some places of the body. And it also actually promotes estrogen receptors in other places of the body. And both premenopausal women, so women who are still having their periods and their ovaries functioning, or sometimes given tamoxifen. So that's if you have breast cancer, and you're younger and your ovaries are still working and your breast cancer is of a lower risk of recurrence. So they only give you tamoxifen and they don't block your ovarian hormone production. So in those cases, those women have lots of estrogen in their bodies and they're taking tamoxifen. And guess what? It works. It works to prevent their breast cancer from coming back, right? It helps treat their breast cancer. So it's working in an environment of high estrogen, right? And tamoxifen, so it's a selective blocker in certain tissues. So that's important for women to understand. Tamoxifen does not put you into menopause. Tamoxifen does not cause you to have low estrogen production. And in fact, when you're on tamoxifen, if you're premenopausal, your estrogen levels are 30 to 50% higher than if you weren't on tamoxifen. In a postmenopausal woman who is using tamoxifen, even there, her postmenopausal levels of estrogen are a little bit higher when she's on tamoxifen. All right. So I know it's a little confusing to patients, but it's because tamoxifen's blocking the receptors. It's not lowering the estrogen. So when we give vaginal estrogen, number one, it's staying locally. We've got very good data that the FDA approved or the government licensed versions are not systemically absorbed. And we have some that are especially low dose. They're all low dose, but there's some that are ultra low dose. And we've got very, very good data that it doesn't increase mortality, it doesn't increase the risk of recurrence, and that it's safe. And it actually helps women stay on their treatments. So that's really important. The other group of women are women who are on tamoxifen and they also have ovarian suppression, or they're on tamoxifen and their ovaries have been removed. So they're blocking estrogen receptors, but they've also had any estrogen also lowered, right? So those are the women who are more moderate or higher risk of breast cancer. And it's not just that, they may be also on something even more severe, which is an aromatase inhibitor, which takes your already low levels of estrogen and makes it even lower, makes it almost zero, right? And so in those cases, women are extra worried about like adding vaginal hormones. And the message we have to explain to them is that yes, systemically, your hormone levels are really low, and you're either blocking anything out there that could possibly be with tamoxifen, or you're lowering it really low with aromatase inhibitors. But even in that case, that local low dose vaginal hormone is staying in that tissue. It's not circulating around. And I know women are doctors get particularly concerned about the aromatase inhibitors because the whole point of them is this very severe estrogen deprivation. But I want to, and I wish we need more data. We want even more data in that population. I certainly would love to see that. But all of the available data that we have suggests that it's safe for us to use vaginal hormones and in those cases. And there are particular formulations that I personally do, tend to use in those patients who are on the most severe form. But anybody listening to this, there are multiple medical societies throughout the world who have professional guidelines on this. We've got multiple studies, incorporating thousands and thousands of women, that showed this is safe. But it's really a trickle down kind of problem. Like the information is still not trickling down to the medical oncologists sometimes, or the local or the GYNs. And so there's still a lot of fear there. So even though women are educated sometimes more, their doctors aren't. And they they kind of hit a brick wall trying to get these prescriptions, right? And they're told to use coconut oil or Crisco or these other moisturizers to treat severe atrophy, and that's just not good advice. Moisturizers have a role, lubricants have a role, but vaginal hormones are actually treats the problem.
Yeah, 100%. And so, have you any tips or phrases that you know that can maybe help in a tricky conversation with for someone listening and they feel that they don't seem to be getting that collaborative approach. Have you any ideas of how a patient might shift the narrative during that tricky conversation with perhaps one of our colleagues who really isn't particularly up to date?
Yeah. So, unfortunately, the burden falls on the patient. But I tell patients, I know it's not fair that we're asking you to become like a medical expert and have to push hard and advocate, but you're worth it. And it really is. So the first thing is you have to know what GSM is, the genital urinary syndrome of menopause, and understand that you can't just tell your doctor it's only vaginal dryness. There are symptom trackers out there, menopauseandcancer.org is an amazing nonprofit that has it. If people go to my link in bio, I have a document that I actually just put up. It's a guide people can download for free that has a list of all the symptoms and a symptom tracker. So you can like mark, mild, moderate, severe symptoms and all of the symptoms, not just dryness, and then a section for comments. So I encourage women to write down all of your symptoms, prepare for your appointment, make an appointment specifically to address this. Don't just surprise them with it. Maybe send a message on your patient portal ahead of time, be like, hey, I want to come in to talk about this problem. I'm having these symptoms, and I want to have an intelligent conversation about the use of local low-dose vaginal hormones. Um, and I want shared decision making and informed consent about this. And also to document what you've tried, right? So what women are told who are breast cancer survivors, and I frankly disagree with this, but this is what the guidelines say, to start with a non-hormonal moisturizers and lubricants. And if those fail, then move on to vaginal hormones. And fine, you want to do that approach, go for it. But what I find is that approach is just kind of kicking the bucket down the road. And women are then, waiting 2, 3, 4 years, sometimes longer, where they're like, okay, it's finally so severe that I can't have penetrative sex. I have trouble having a pap smear. I can't get my cervical cancer screening because I can't tolerate a GYN exam anymore. I've had recurrent urinary tract infections. I'm on chronic antibiotics. We don't really want to get to that point. And I can promise you a lubricant that decreases friction during sex doesn't treat these things. It only stops friction. Moisturizers are great. I don't think that they should be abandoned. I think you should use them early, use them with your vaginal hormones. But you know what? It's not going to prevent UTIs. It's not going to solve clitoral atrophy. Let's call it what happens. That's what happens. The clitoris atrophies. It's not going to cause, thinning of the labia. It's going to provide you some comfort. Might temporarily plump up the tissue and help it be a little hydrated, and that's great. But again, it's not going to fix the underlying problem. And so, these are the things that you have to understand and know before you go in. And then when someone says no to you, I understand, doctor, you are concerned for me. Can you please show me what the latest guidelines are? Or can you show me the data that shows that it increases mortality or increases recurrence? And the thing is, they will not be able to show you that data because it doesn't exist. So call their bluff. Say, like, I want to see, show me the data that shows that it causes an increased risk of recurrence. And then you have to have it prepared. You should print out the guidelines. And we share them all the time on social media and on your podcast and other sources. The menopauseandcancer.org is a great place. So kind of track your symptoms, have your script on how you're going to talk to them, give them advance warning so that they can be prepared for your meeting. Demand receipts, meaning make them show you why they're telling you what they're telling you. And you could also say, listen, I get that this is not your area of expertise. Can I have a referral to somebody like you, for instance, who could help? So, oncologists have a lot on their plate. They sometimes they don't feel comfortable with this, and that's okay, but they have to know who they're going to refer these patients to, because it's no longer acceptable to just tell them to deal with it.
I do have a dear friend who gifted her oncologist a copy of Estrogen Matters by Avram Blooming and Carol Tafris. It didn't seem to go down that well, but she left it on the desk for him anyway.
Well, listen, to me, if a doctor's not willing to learn, then they should really reconsider their career. Because as a physician, you have to always be learning because medicine is always evolving, right? I didn't know these things years ago and I had to learn, right? And I learn every day. I look things up and it's Patients are appreciative when you're humble and say, you know what, I'm not really sure. This is a tricky case, or you know what, I'm not super comfortable with this, but I hear you and I see that you're suffering, and I'm going to, let's have a follow up, or let me speak to my colleague. Or you can't just write patients off, and particularly women have for, since eternity be written off, but it's just not acceptable anymore.
No,
There's something
100%.
called the internet, and you can look things up,
Yeah,
right?
that's right. Here are my 3 takeaways from today's conversation with Dr. Corinne Menn. Fear comes from flawed data, not from hormones themselves. Context matters. The type of cancer, timing, and formulation change the equation. And conversation is care. Women deserve nuanced, evidence-based options. Thank you, Dr. Corinne, for your clarity and advocacy in helping women move beyond fear and into informed choice. You can find links to Dr. Corinne's social channels and the latest research summaries in the show notes. If this episode resonated with you, please follow the show and share it with a friend. And remember, this information is general in nature and not intended to replace personalized medical advice. Always speak to your healthcare provider for your guidance about your own situation. I'm Dr. Shauna Watts, and I'll see you next time on All About You.